Good morning, good afternoon, good evening from wherever you are in the world. We're just going to give a couple more minutes for Katerina to get everybody into the room. I see we're at 70 participants, still some people coming in. Excellent. Okay. So we'll get started just because we have a very full time that we're hoping to share stuff with you over the next hour and a half. My name is Lauren Beaupre. I'm a physiotherapist and a professor in physical therapy at the University of Alberta in Edmonton, Canada. And I'll be doing the easy part of introductions. My co-chair is Katie Sheehan. Katie, do you want to do a brief intro for yourself? I'm making Katie do all the hard work today.
Hi, everybody. I'm Katie. I'm a professor of rehabilitation at Queen Mary University in London. I'm excited to be here.
Great. So we have four presentations that we're going to give to you. And our rationale for doing this webinar is that we've recently developed through the Fragility Fracture Network an early mobilization module that will become freely available on the FFN website shortly. It's not available yet, but it will be released in the next a week or so, we hope. This is really to help people to be able to come in and get some basic knowledge about how you might introduce early weight bearing, early mobilization following hip fracture. So today we're going to do four talks of about 10 minutes each, and we're going to put some questions in between to get a sense of who you guys are and the kind of practice and the areas that you work in and where you're coming from. We'll open up the time at the end for some questions and answers. I believe that you can put, I'm just looking down here, write your questions in the chat, and we will be open for questions at the end of the presentations. And yes, I can see this. This is being recorded. Thank you for that. Yes, it has been recorded. I think you can probably see up in your upper corner that this will be a recorded lecture and will be released on the website shortly after this webinar ends. So probably because it's late in the day for Katerina, it'll probably be tomorrow before you see it, but it will be released for people to go ahead. So Katie, why don't we let this, and I just want to say this module, it's really exciting for us. This is this early mobilization module, that it was developed really using a very collaborative effort with input from multiple disciplines from around the world that really got to weigh in on what was important to create in a basic webinar for about early mobilization. So we're really pleased to share the highlights of it here today and hope you'll enjoy the module once it's released. Katie, over to you to do sort of a check on who people are here.
I guess first of all, it'd be really great if people could pop into the webinar chat, your name, where you're from, so we have a sense of everyone who's here and everyone can say hi to each other. And then we're starting off with an introductory survey. Kathy, I believe you're going to pop this on screen. Is that right?
There you go.
So we can get you to click on the survey on screen. So we're looking at two questions for initial thinking. What proportion of hip fracture patients are out of bed, standing and taking steps, if they're able to, within 24 hours of surgery in your setting? So you've got a couple of options: 0 to 25%, 25 to 50%, 50 to 75%, 75 to 100%. Or if you don't want to answer that question, that's completely fine. And then the second question: who's involved to ensure mobilization is a success in your setting? And if you can tick all of those that are involved, surgeons, other physicians, physios, nurses, granted, occupational therapists are also involved, but we don't have a box for them. So if you can just tick among the options that are available to you. And we'll just leave it a little bit.
Great to see the Canadians showing up here too. Do we want to scroll, Katie, do you think? I think
so. I think Kathy, we could probably move to, scroll. Sorry, question 3. When should a patient get out of bed? The day of or after surgery, within 4 days or within a week? Okay, so we've got our results. So we've got kind of 39% of people saying that 75 to 100% are out of bed, standing and taking steps within 24 hours. And then right the way through to 8% saying that really it's only a quarter of patients that are achieving that. Um, we can see that it's great to see, oh, the scroll down. I was wondering on my screen, I couldn't see occupational therapists, but we can see that it's wonderful that it is a multidisciplinary effort to support mobilisation success in settings. And then most people are saying that we should be working towards day of or after surgery. So we're at a great starting point for the module. So I'll close that poll and we can pass on to our first speaker.
Okay, so our first speaker is coming to us from Portugal, and Carmen Quiros is a rehabilitation nursing specialist who holds a PhD in nursing sciences and is currently working at the nursing school at the University of Porto in Portugal. And she also serves as the vice president of the FFN Portugal and the secretary general-elect of the Global Fragility Fracture Network. And Carmen is going to start our talks with why mobilization matters. Carmen.
Thank you, Lauren, and thank you for everybody who is attending this lecture today, and I hope you enjoy it. Today, I will talk about why mobilization matters. I will share my screen. I just want to some okay when I start sharing. Are you seeing it?
No, not yet.
Not yet. Just... Okay.
Oh, there,
And
yeah.
now?
Yes.
Yes? Okay. So let's start the lecture. Early and continuous mobilization is one of the most important interventions following a hip fracture surgery. And evidence consistently shows that patients who mobilize early experience better outcomes, including lower mobility, fewer complications, and greater preservation of independence. Importantly, the care that is delivered during the first week after surgery has a significant impact on recovery trajectories and long-term outcomes. So, a hip fracture is a life-changing event, often marks a major turning point in an older person's life, and without effective rehabilitation, many patients never regain their previous level of function. That's why early and continued mobilization is a cornerstone of recovery, because it helps prevent complications, supports independence, and improves overall outcomes. Mobilization should be considered a core treatment rather than an optional rehabilitation activity. So why and what is early mobilization? There's some different literature about this, but in our course, we defined it as early mobilization refers to the initiation of upright functional activity out of bed, typically on the day of or the day after surgery, within 24 to 36 hours, and includes standing or sitting out of a bed in a chair or ambulation with or without assistance or devices. And what are the guidelines for early mobilization? There are lots of organisms that set guidelines, and the clinical guidelines recommend that mobilization out of bed within 24 to 36 hours that is progressive from sitting to walking based on patient stability and tolerance. Mobilization practice varies due to weight-bearing order interpretation and staffing, environment, and safety concerns. And that's why education and pathways are important and improve adherence. So what are the causes of immobility? When patients remain inactive following hip fracture surgery, recovery is delayed and risks increased. Immobility is associated with increased mortality, prolonged hospitalization, reduced return to pre-fracture function, and greater dependence on others for care. So older adults can decondition rapidly, and even short periods of bed rest can have significant consequences for strength, mobility, and overall recovery. So there are up to a cascade of complications. We can talk about venous thromboembolism. That includes deep vein thrombosis and pulmonary embolism. That is a serious risk for patients who remain immobile. When patients do not move regularly, blood clot in the veins slows down, increasing the risk of blood clots forming. So early and ongoing mobilization helps improve circulation and can significantly reduce the risk of venous thrombosis. And furthermore, immobility increases the risks of pneumonia by reducing lung expansion and making it harder for the patients to clear respiratory secretions. So this can lead to chest infections, which are a significant cause of complications and mortality in patients with hip fractures. So early and continued mobilization can help improve lung function, support air clearance, and reduce the risks of this complication. But there are more complications. The prolonged immobility that places constant pressure or vulnerable areas of the skin, reducing blood flow and increasing the risks of tissue damage. And this can lead to pressure injuries, which are painful, slow to heal, and may become infected. So early and continued mobilization helps relieve pressure, improve circulation, and maintain skin integrity, reducing the risk of pressure injuries. Delirium is also a common and serious complication in immobilized patients following a hip fracture. It can also develop quickly, and it is associated with longer hospital stays, increase the risk of long-term cognitive decline, and greater dependence after discharge. So early and continued mobilization can help reduce the risk and severity of delirium by promoting orientation, engagement, and overall physiological stability. Furthermore, early and continued mobilization after hip fractures surgery help reduce muscle loss by maintaining muscle activity and regular weight bearing. In contrast, delayed mobilization can lead to rapid muscle wasting, particularly in the quadriceps, due to the effects of prolonged mobility. So, starting mobility within the first few operative days is strongly linked to better muscle preservation and improved functional recovery. So, in synthesis, early and continued mobilization after a hip fracture surgery is associated with reduced mortality, largely by lowering the risk of postoperative complications such as pneumonia, thromboembolism, and cardiovascular events. Delayed mobilization increases the risks of complication related to prolonged bed rest, including systemic deconditioning and overall clinical decline. And starting mobilization early in the postoperative period is therefore strongly linked with improved survival outcomes. In addition, early and continued mobilization supports better physiological stability and helps reduce inflammatory and thrombotic risks. It is also associated with shorter hospital stays, which in turn are linked to lower morbidity and mortality in older patients. Immobility, worse functional decline, and highs fall-related worry, which contributes to depressive symptoms, while also accelerating deterioration in executive function, mobility, and overall independence. So, early and continued mobilization can interrupt this cycle by helping and improving physical function and independence and reducing risks associated with cognitive impairment. And we also need to consider that when patients are encouraged and supported to get out of bed early, standing, sitting in the chair, or start walking, they move from being passive recipients of the care to becoming active participants in their own recovery. So we are empowering the patients. And this active involvement can strengthen their confidence, their motivation, and sense of control, instead of perceiving recovery as something that is done to them. Patients begin to understand that they have an active role to regain function, independence, and autonomy. And this sense of participation is particularly relevant in rehabilitation because engagement is essential for adherence to therapeutic activities, progression in mobility, and achievement of recovery goals. Therefore, early mobilization contributes to physical outcomes, but also to psychological and behavioral outcomes, supporting better engagement and rehabilitation, and ultimately better overall recovery and improvement of quality of life. So, every step counts. Early mobilization within the first 24 to 36 hours after surgery should be understood as an essential component of postoperative care. When safety planned and adapted to the patient's clinical condition, early mobilization helps reduce postoperative complications such as functional decline, respiratory complications, thromboembolic events, loss of muscle strength, and prolonged dependency of others. So the central message is that early mobilization is not optional, is an essential treatment intervention that supports recovery, promotes independence, and contributes to better clinical and functional outcomes. With this say, I finish my presentation, and I'm here for any kind of questions that you may have. Thank you.
Thanks so much, Carmen. And Katie, I'll put it over to you as well. Thanks very much. That was an excellent talk, Carmen.
Lovely. So we're on to our next poll, which is a quick knowledge check to follow on from Carmen's presentation. I think this should come up on the screen shortly for people now. Lovely. So we're looking at a quick question. Which of the following is a result of early and continued mobilization after hip fracture? So you pick one. Is it deteriorated wound healing? Is it increased mortality? Is it reduced delirium risk or reduced chance of functional recovery? And we'll just give people a minute or so in order to populate their responses to that question before we move on to our next speaker.
Joanna, just as we're waiting for this to come up, do you have any comments? I know Carmen talked a little bit about the importance of engaging patients and making them be active partners in the recovery. And Joanna is a qualitative research scientist from Canada who does a lot of work with patients in terms of patient experience and qualitative research. So Joanna, any comments you'd like to add?
Thanks, Lauren. So we don't hear a lot about early mobilization from patients. It's mostly, I think they don't really remember this part of their in-hospital stays. So we often don't get, I think I'll have a little bit more to say about sort of after the early mobilization from the patient perspective. But yes, they often don't really talk about those early days after surgery. So I don't really have a lot to say on that phase of the work.
Okay. Yeah, and I think it is this important part though that right from the get-go, I think our goals as care professionals are to make the patient part of the journey, not as somebody said. I think you said so eloquently. It's not being done to them; it's being done with them. They need to engage to sort of see that their role in their own recovery as well. And did the outcome come up? Did I miss it, or it has not come up yet, Kat? There we go. Okay.
So yeah, so we've got 94% of people pointing out that early and continued mobilization does indeed reduce delirium risk, which is obviously something that we're targeting for our patients. So we can pass on to our next speaker. We have got a question or two coming through in the chat, but I wonder if we look to address all of them during the Q&A at the end of the speakers.
Sure. Should we do it that way, Katie? Maybe we'll just keep going and then we'll have more time for Q&A. We'll go back and revisit these questions. Yeah. Sure.
But do keep them coming because we will look to address them.
Yes, exactly. This is very much, we'd like it to be some interaction as well. So our next presentation is clinical decision-making, who's ready to mobilize? And so our second speaker is Shanil Namdari, who is a emergency care MSc physiotherapist who works at the University Hospitals Birmingham in the UK. He has a research background around trauma and orthopedics. And he actually was presenter at our last fragility fracture network conference in Porto last fall. On early mobilization and rehabilitation and fragility fractures, reporting really from what was happening in the UK. And he also was one of the people who helped develop the module, as was Carmen. So Chanel, I'll pass it on to you to carry on with clinical decision-making. Who's ready to mobilize?
Hello, everyone. I'm glad to be here today. Hope you enjoy this presentation. I'm just going to share my screen now. Can everyone see my screen? Yeah. Okay. So clinical decision making is essential to determine if a patient is safe and ready to mobilize. It mainly consists of assessing physiological stability, cognitive status, and functional ability. So these guide clinicians to balance the benefits of early mobilization against the potential risk to ensure patients' safety for an optimal recovery. So early and daily mobilization is the foundation of recovery. So a multidisciplinary team such as nurses and physiotherapists work together to encourage safe movement whilst adapting to individuals' needs towards patient independence. Early mobilization refers to the initiation of upright functional activity out of bed, typically on the day of or the day after the surgery, normally within 24 to 36 hours, we say. It includes standing, sitting out into a chair, or even mobility, either aided or unaided. On the other hand, daily mobilization involves encouraging patients to mobilize throughout the entire day as part of a continuous 24/7 rehabilitation program, rather than only during a single physiotherapy session that generally might last maybe 30 minutes max. On the other hand, this daily mobilization approach encourages patients to mobilize. So it's not a case where we have to be in the session for them to engage, and then throughout the rest of the day they are just going to be there sitting in bed or sitting out on the chair. It just gives them a bit more independence there. So this is why patients should aim to mobilize across the whole day by themselves, as long as they're safe, obviously, with a gradual progression with that. And this early rehab is a shared responsibility where all healthcare staff should support and promote mobilization during routine care and interactions, provided it is safe to do so, obviously. And the consistent daily movements support muscle strength, joint flexibility, stamina, and physiological well-being. Ultimately, it also reduces the risk of complications associated with prolonged bed rest, such as deconditioning, pressure injuries, and other immobility-related issues. Right. After a hip fracture, weight-bearing status refers to how much body weight a patient may place on the affected limb during standing and mobilization. It may range from non-weight-bearing, where no weight is placed on the injured leg, to limited weight-bearing, where only a portion of the body weight is allowed, to unrestricted weight-bearing, where the patient can fully place his full body weight on the leg without any restrictions. And traditionally, the level of weight bearing was determined by the type of fracture, the stability of the surgical repair, and as per the surgeon post-operative instructions. The current weight bearing standard of a hip fracture surgery is weight bear as tolerated, meaning the patient can place as much as weight as they're able to immediately after surgery. In practice, this usually means unrestricted weight bearing from the time the patient leaves the operation theater, even before the post-operative x-ray are even reviewed. So this reflects the aim of modern surgical management, which is to provide sufficient stability to allow early loading and mobilization. Weight-bearing restrictions are not a routine and should not be applied if specifically indicated by an orthopedic surgeon. So when these restrictions are required, they should be very clearly justified and documented based on the fracture stability or the individual patient factors, and this should be time limited and regularly reviewed. The next slide here is a QR code that just reflects the FFN's position and unrestricted weight bearing of the hip surgery. Right. So readiness assessment is the foundation of safe mobilization. It helps identify risk and ensure patients are prepared for movement, reducing the likelihood of complications. Let us explore the first part here on pre-fracture functional baseline. The purpose is to establish the expected mobility potential before the first mobilization process. Some key assessment tools that are used are the new mobility score, which is preferred pre-fracture function, and the cumulated ambulation score. And what does this determine? It determines the independent walking ability, both indoors and outdoors, the use of any walking aids before the fracture, and the transfer independence, and obviously the baseline mobility. So what is the clinical significance behind this? It is the strongest predictor of an early mobilization success, which guides the level of assistance, goals, and pacing of rehabilitation. Now moving on to the second part here on surgical and fixation stability. The purpose is to confirm mechanical readiness of the operated hip. And there are some checklists that's listed here. And what is the clinical impression here? So weight bear as tolerated means a full mobilization pathway is possible, whereas a restricted weight bear status can limit to only bed to chair transfers or assisted standing. So it removes a sort of independence there. And onto this third section around medical and physiological stability. The purpose here is to ensure the patient can safely tolerate upright positioning. Some core stability criteria to be respected are listed here. And looking now at the fourth section, we will explore the neuromuscular activation readiness. So the purpose here is to confirm if the patient can activate key lower limb muscle groups required for standing, weight transfers, and safe stepping before first mobilization. And some key assessment pre-mobilization can include the ability to activate quadriceps on the fractured limb, look for visible or palpable contraction, even if it is weak, or note any mark inhibition due to pain or swelling. The clinical interpretation here can be viewed as with an adequate activation present. So we proceed with standard assisted mobilization. If we have a reduced but present activation, proceed with increased assistance, cueing, and close supervision. And if there is absence or very poor activation, then we'll anticipate a difficult transfer and consider pre-mobilization activation exercises and a delayed progression of an upright activity. So this one is a very important section about orthostatic blood pressure, which many clinicians might miss. So the rationale of allowing standing blood pressure is to detect hidden postural instability before mobilization. It is assessed in lying, then standing for 1 and 3 minutes. It is essential to record both the blood pressure and the heart rate in both positions. And a positive finding is a systolic drop of 20 or a diastolic drop of 10 or any accompanied symptom or dizziness, for example, or pre-syncope. And the mechanism of action is to monitor symptoms such as dizziness throughout. If a mild drop, then proceed with close supervision for mobility. And if there's a significant drop, then we need to address the causes and delay mobility. And there are also some additional medical factors to consider prior to mobilization, which are briefly outlined here. Okay. Another key factor to consider is the cognitive and behavioral readiness. The purpose is to ensure the safe participation and the ability of patient to engage in movement. So the delirium screening outcome measure is to be completed prior to mobilizing any patient, and this can detect acute cognitive impairment risk. We interpret the 480 outcome measure by 0 to 3. Delirium is unlikely. And if it's greater or equal to 4, there's possibility of delirium where we should mobilize with supervision or assistance. Some additional cognitive checklists here can also be performed, and we can ensure some sensory aids are also in place to optimize orientation and communication. Could it be reading glasses or even hearing aids? And here again, the key principle is that cognitive impairment does not automatically delay mobilization. It only modifies what sort of supervision or support level we need to give. And the final part here is the environmental and organizational readiness, where the purpose is to ensure safe conditions for mobility delivery. And again, we got some checklists that are briefly listed here. We also need to confirm the system readiness, such as the MDT communication. Has it been completed or not? If the mobilization pathway protocol is in place, or is the staffing enough to support early mobilization timing? And on this slide here is just a recap of what we discussed above prior to immobilization decision. So when should mobilization be delayed due to surgical factors? So if we have a fixation that is unstable, if the surgeon prescribed non-weight bearing, if there are any post-op complication affecting surgical safety, our safety of the fixation always takes priority before mobility. So when should, on the other hand, should mobility be modified due to surgical factor? So if we have a partial weight-bearing status is prescribed, this is one of the reasons. And if there are complex fractures required, then this will involve graded loading. And if a full gait training is not permitted, then these are situations where we would have to modify it. Then we would also, in this case, what we will do is we will just use assisted standing or bed to chair transfers only, either aided or unaided. So I'm just moving to the next slide now. So this time, when should mobilization be delayed due to medical instability? So some medical complications are listed here. And we should always ensure that the patient stabilizes first before any mobilization. On the other hand, when should medical issues lead to a modified mobilization? Here we would modify mobilization in some of the listed cases here. And in this situation, we would use short, assisted, and closely monitored mobilization. Right. And so uncontrolled pain delay mobilization. Poor analgesia reduces functional performance and increases the risk of failed or unsafe mobilization attempts. So once pain is controlled, graded mobilization should proceed. And we should aim to optimize analgesia before progression. And here, the pain assessment scale, the verbal rating scale, is scored between 0 to 4, where 0 is no pain, to 4 being unbearable pain. And the pain should be assessed at rest and during activity to guide mobility decisions. And when should we modify our mobilization accordingly to pain? So if the pain is between 0 to 2 during activity, and if movement is tolerated within support, and if the analgesia is improving pain but not fully optimal, then we would use slower, assisted, and closely supervised mobilization. And on the other hand, so when would mobilization be delayed or adjusted? So when the pain score is greater or equal to than 3 at rest or during activities, or when the pain prevents active participation or muscle activation, or the pain remains uncontrolled despite analgesia. So in these cases, we will aim to optimize analgesia prior to reassess before any progression. So last slide here. So in the last slide, we will explore when should cognition delay mobilization. So it would, in cases of severe delirium or agitation causing unsafe behavior where safety risk overrides mobilization. And ultimately, when should cognitive issues lead to a modified mobilization? So we would modify mobilization when there is a mild to moderate cognitive impairment is present, or when a patient requires frequent cueing or supervision where mobilization remains beneficial with support. That's everything for myself.
Great, thanks, Neil. And I see some really interesting questions coming up here, and we will revisit them and circle. And I see some excellent responses happening within people as well. Katie, you have another a scenario to share, I think, this time.
Yes, yeah. So if we can get the patient scenario up on the screen, please. Okay, So we've got Mrs. K is an 82-year-old patient on post-operative day 1 following a hemiarthroplasty. She's been prescribed weight bearing is tolerated and is experiencing moderate pain despite analgesia. In the supine position, her vital signs are stable with a blood pressure of 128/74, heart rate of 80 beats per minute, and O2 sats of 95% on room air. During early mobilization, when assisted to sit at the edge of the bed, Mrs. K reports dizziness and appears pale. What should be done in this case? So should you proceed to standing with the walking frame, pause, maintain seated position, reassess symptoms and blood pressure, or return to lying and cancel mobilization? So we'll just give you a minute to decide on what you think the best course of action is for that patient scenario.
Okay, we probably have responses coming up fairly quickly, I would think. There we go. Excellent.
So 95% are saying that pause, maintain seated position, reassess symptoms and blood pressure, which would be the recommended course of action, in the hope that it'll settle and that you can get Mrs. K up into standing thereafter. Okay, so we will move on to our next speaker. Over to you, Laura.
Thanks, Katie. So really excellent to hear the conversation in there, that people are getting the idea that delay means and really moving to modify over delay, which is great. I think that we need to not look for opportunities to cancel mobilization, but instead look for opportunities to modify and carry on in some adjusted way. So our third speaker is going to talk about delivering mobilization, the multidisciplinary team, and common barriers. Rona McGlasson is a Scots who is now Canadian and has a physiotherapist, but also has an MBA, and she is the Chief Operating Officer for the Global FFN, and has been very much behind a lot of this module development and driving forward sort of orthogeriatric certification, which includes early mobilization. So Rona.
So thank you. Thank you to the speakers, and thanks to everyone for attending. I'm going to take you through a short journey here, just around who is involved. We've already presented some of it, so I'm going to maybe put a little bit more meat on the bones for this one. So when we look at early mobilization, what we're looking at doing is coordination between the multidisciplinary team. The focus really is on achieving the patient's goals, and we've talked a lot about the different staff, and we'll go into a little bit more about the staff, but they really need to be appropriately trained to actually support the delivery of safe and consistent mobilization. So what we'll do is just have a look at some of the staff that are involved. When we had done a little bit of this work previously with respect to mobilization, we hear consistently around physiotherapists and very much a lead role with respect to mobilization, both initiating the exercise we've talked about, the gait retraining, really promoting the unrestricted weight bearing and restoring strength and mobility. We also need to consider the nurses. We've talked a lot about daily mobilization and keeping the person active through the day. So nurses have a very important role around the whole activity for keeping people transferring, standing, monitoring their pain and their vital signs during the mobilization. So when we go on to some of the other professionals, we obviously have the geriatricians and the physicians, looking at optimizing the management and the comorbidity of the different medical conditions, and looking at opportunities for improving their pain management, and really promoting the medication management about all the complications such as the delirium. We've also talked a lot about orthopedic surgeons, and so they are critical. Orthopedic surgeons are the ones who are doing, obviously, the surgery, but we need that surgery to be the right surgery. There are all different types of implants, and the surgeons really need to make their primary focus of the surgery that they do a type of surgery that will allow the person to be weight bearing. And so in that context, they then need to go on to think about ensuring that if there are going to be precautions, that those precautions are identified, and it's not just non-weight bearing for the next 6 weeks, but it is something that is being evaluated consistently, and that is being that the team has the ability to move forward on, so that the person can get that leg down and can become as fully mobile as possible in the shortest period of time. So there are other people involved. We have occupational therapists, extremely important. We want to get these individuals back to being as functional as possible. We want them to be moving up to the washroom, doing their personal hygiene as quickly as possible, as well as looking what the whole program we heard from our last talk around the mobilization has to be based on what was the person doing before they came in, before they had their hip fracture. So occupational therapists are extremely important in identifying that and returning the person to that level of function. Pharmacists, making sure that there's effective pain control. The whole focus of FFN is an orthogeriatric approach. And so that really looks at not just the fracture, but the whole frailty for patients. And so we really want to make sure that we are targeting the issue with drug interactions, and making sure that we have a good drug regime, so that we can promote the safe, functional return. So the whole team is involved throughout this process. So we have social workers. Again, we go back to this is all about discharge planning, and getting the person back to their pre-function level. The focus for nutrition is critical. We're going to be doing a lot of work through FFN around nutrition. And there's so much evidence now about protein intake, and we know that we reduce calories when people are in hospital, especially those that are frail. So we have a significant program called Simpler. It's on the FFN website that really looks to increase nutrition intake for patients through this recovery process. And all of the staff that we've talked about already are very important to making sure that there's not just a thing of ensure at the end of the table, but the person's actually consumed it, because we need to make sure, and for a full recovery and to rebuild the muscle mass, that they are participating in some kind of nutritional supplement. Obviously, psychologists can be very important as well along the way, related to issues with fears, anxiety, fear of falling, reduced confidence. So we want to make sure that that's all being addressed along the way as well. So there are some pathways that we can consider for making sure these multidisciplinary teams can work closely together. One of the important pieces is this structured bedside handovers to communicate mobility status, to communicate risks, and to make sure that the patient's goals are being considered across the continuum. All kinds of things could be used, visible mobility boards, making sure that there's information around the weight-bearing status and mobility levels, documentation, tolerance, multidisciplinary meetings, ward huddles, escalation pathways. What I'm also going to add in here is one of the other most important team members is the patient themselves, as well as the caregivers associated with it. So as we look at these communication pathways for our early mobilization, we really want it to be done in a way where it is clear to the patient and clear to the family members what the goal of mobilization is, as well as what the status of their mobilization is, so that they can be actively engaged in participating in helping the person stand or clean their teeth or doing some functional activity as quickly as possible to embed it much more into function. So other things that we need to consider in the coordination of care is aligning the mobilization across the nursing, physios, and medical team. So when is the physio available? When are they coming in? What are the nurses going to do? Setting the mobilization targets again, we've talked about mobilization pathways and pre-mobilization checks of everything we talked about before, so that we're consistently assessing and developing goals of what we're going to do with the patients. Supporting tasks between staff and making sure that we're all working to our scopes of practice. That's different in different countries. The way staff work and professions work in different countries does vary. But we want to make sure that this whole focus of mobilization is something that is embedded in what everyone can do, so that they can complete their activities and work consistently throughout the day with the patients. There's certainly administration things that need to be considered. And again, in the last presentation, we talked about it around walking aids and equipment, which needs to be available and really needs to focus on getting the patients home. So there are some barriers. Pain, analgesia. We want to make sure there's peak analgesia to improve tolerance and function. Mobilization and protein, we've talked about already. We want to really think about that intake and getting people up and functioning with the maximum protein intake. Upper extremity problems, absolutely. We want to make sure people can adapt to their walking aids and support. Concerns about falling, we need to make sure that it's always done in a safe environment, because we want to make sure that people are getting a positive reinforcement and building their confidence in their mobility, as well as working with the carers and caregivers to do that. Cognitive impairments we've talked about. We want to make sure that we're addressing anything, identifying and addressing cognition very quickly. Limited pre-fracture mobility. So our end goal is to return the person to what they were doing before they came in. So we want to make sure that we really understand what that is, and that we're aiming towards a realistic goal of returning to function. There's also always resource limitations, equipment, space, trained personnel that can restrict safe mobilization. So the more that we can standardize process and protocols, the less that they're going to be an issue. There's cultural variations, certainly that happens between countries, but it also happens in Canada. Is very multicultural. It happens within cultures, within a single community. So we want to make sure that we really do provide cultural education, so that we can respect people's cultural perspectives, but we do make sure that we have a process in place that is a standard protocol for all staff. Communication breakdown always happens. All we can do is ensure clear communication and regular communication to maintain consistency in how we approach it. Surgeon preference is something that the more, again, we have a standardized protocol, we will reduce unnecessary variation. Most hospitals, or a lot of hospitals, also have a secondary way if there is significant variation between surgeon practices, that the surgeons will come together and develop an agreement on what those practices are. So it becomes an organizational approach to care rather than allowing surgeons to have significant differences in their practice. Hypertension, we've talked about that, and there were some practical tips given earlier around changing and modifying, and again, comorbidities, optimizing medical management, but we making sure that the team are considering that and are modifying rather than cancelling mobilization. So I think that through what we have seen here is that there is an opportunity for innovation, and it really is this coordinated approach of care for a reality to make this a real for every patient. One of the things that I'm just going to quickly touch on, one of them is one of the biggest factors we have, and we have learned this, we're doing certifications, or orthogeriatric certifications for different hospitals around the globe. And when we get that information back, weight bearing is one of the most significant challenges that a lot of sites have. And so a lot of it's related to communication, but it's also related to resources. And one of the things that we've added into this certification is what we do during the week versus what you do at the weekend. So please go onto our website, find out more about this certification. But my only point really here is make sure as you're thinking about what your plans are and developing these standard approaches to mobilization, you do think about not just what happens on a Tuesday or Wednesday, but what happens to patients on a Saturday or Sunday. Because what we have found through this process is that varies dramatically. I think, Katarina? Thanks. So I think that's the end. So thank you for that.
Great. Thanks, Katie. I'll pass it back to you. Thanks, Rona.
Thanks a million for that, Rona. I think we have another quick knowledge check. So hopefully that'll be coming up on your screens shortly.
So, and I think one of the things, as Rona's talked about, and the FFN, because we work globally, we do see really large differences in resource availability, discipline availability across countries, across cultures. And I think when we talk about the multidisciplinary team, I think we also have to think about interdisciplinary. You make do, and you figure out how to do these things with what you got. And I think the big process is, again, it's basic, very patient-centered. What do you have to do to be able to get this patient up and moving? And in some cultures, that may be involving your family, and maybe nurses working differently because there's not a lot of the rehab staff around, and whatever makes it work for you. When we talk about multidisciplinary teams, it's like, what do you have and how do you make it work in your setting? Because some of us are fortunate to have a lot of these resources and some less so. Katie, sorry.
Okay, absolutely true. So our quick knowledge check here. Which practice best supports effective multidisciplinary team communication during early mobilization after hip fracture surgery? So we've got the options of relying on individual staff memory of the mobilization plan during each shift, using structured handover, shared documentation, and clear mobility status update across the team, allowing each discipline to independently decide mobilization goals based on experience, or communicating changes only during weekly ward rounds. And then our second question, which statement best reflects effective multidisciplinary team coordination in early mobilization? Is it mobilization should only occur when physiotherapy staff are available? Each profession completes its role independently before mobilization begins. Mobilization should follow a shared pathway so any trained staff member can safely continue the plan. Or coordination is only required during discharge planning, not during daily mobilization. We'll just allow a minute for people to ponder on their responses to the poll.
Okay.
We've got 99% using structured handover, shared documentation, and clear mobility status updates across the team for the practice that best supports effective multidisciplinary team communication. I was wondering if people got biased by Lauren, who nodded when we got to that response option. And then for our second question, so the statement that best reflects effective multidisciplinary team coordination, we've got 90% said that mobilisation should follow a shared pathway so that any trained staff member can safely continue the plan. And I think that's feeding back into the point of that mobilisation is a care process rather than a physiotherapist's job. And that really we need to be making sure that patients can get up early safely by any profession who is equipped to do so. Okay. So we're over to our next and final speaker, I believe. Yeah.
Okay. So finally, we have Christian Terrelson, who's going to talk about beyond walking, exercise and person-centered recovery. And Christian is a professor in physiotherapy for older adults who works within the Department of Rehabilitation Science and Health Technology at Oslo Metropolitan University in Oslo, Norway. Again, she's part of the FFN Special Interest Group, Fragility Fracture Recovery Research, and has worked in clinical research that's focused on mobility after hip fracture and increasing physical activity areas. Kristen.
Thank you, Lauren, and hello, everyone. So, early mobilization after hip fracture should be guided by a personalized mobility care plan based on the older adult's current mobility level. And the care plan should include core mobilization activities and natural opportunities for movement during the day. But also respecting the older adult's preferences and abilities. So now we will explore mobilization strategies for each mobility level. Here you can see examples of core mobilization activities for those who are independent and those who need assistance. The activities include ambulation with or without walking aids and strengthening exercises. In addition, one should use natural opportunities for ambulation throughout the day, such as participating in personal care, walking to the bathroom, and eating sitting up. Another example is bed to chair and chair to bed transfers, 3 times or more per day, in addition to range of motion exercises and strengthening exercises when seated. For persons unable to stand and transfer, they should be transferred using transferring aids and be seated for periods during the day, and also be repositioned at minimum every 2 hours. For progressing mobility, keep in mind to start easy. Simple sitting and standing before more complex and demanding activities. Always have your attention on the patients for pain, fatigue, or other signs. Mobility levels should be well documented, including how much assistance and tolerance, and also the barriers for mobilization. So, for patients who can follow simple instructions, they can do active in-bed exercises independently or with supervision. This to increase functional recovery, strengthen mobility, and reduce care needs, among others. For patients unable to participate independently, passive or assisted exercises are important. But exercises should always follow local protocols, weight-bearing restrictions, and surgical precautions. But cognitive impairment should not exclude patients from rehabilitation. Active exercises are used when the patient can actively participate, such as ankle pumps and circles, static quadriceps contractions or static gluteal contractions, heel slides, hip abduction, adduction, and in-bed cycling. Passive exercises are used when the patient cannot actively follow instructions. with much of the same activities, yet with assistance or passive motion. Exercises should be monitored carefully and modified if required. Should be stopped or reassessed if pain significantly increases, vital signs become unstable, surgical precautions are compromised, or the patient becomes distressed or fatigued. But you should also please consider cognitive status, nutrition intake, and remember that exercise intensity should match the patient's medical stability. In addition to mobility training and weight bearing, exercises that typically are used in hip fracture rehabilitation include gait training, balance and functional training, resistant strength training, endurance exercises, and flexibility exercises. These exercise programs vary in terms of dose, level of supervision by health professionals, and setting, including hospital, outpatient clinics, and home-based programs. Exercise is a core component of rehabilitation across the entire recovery pathway, from early inpatient recovery to long-term community rehabilitation, helping restore mobility and independence. Guidelines include recommendations for structured exercise types, including progressive high-intensity resistant training, balance training, weight-bearing exercises, and functional mobility training. The whole multidisciplinary care team should support exercise and exercise adherence after hip fracture, and that includes the physiotherapists, nurses, and other healthcare staff. Effective communication is essential for ensuring patients and carers feel informed, confident, and engaged. Poor communication contributes to uncertainty, anxiety, and role confusion during care transitions, while clear, consistent, and inclusive communication improves confidence and supports recovery at home. Patients and carers often need timely, understandable explanations about mobilization goals, weight-bearing status, expected progress, and how to respond to difficulties or setbacks. And the information should be consistent and not fragmented, perhaps using ongoing, verbal, and written or visual information. Patients recovering from hip fracture surgery are often older, in pain, distressed, or experiencing cognitive impairment, all factors affecting the ability to understand mobilization plans and make informed decisions. So ethical considerations include patients may struggle to recall information, cognitive impairment may affect decision-making capacity, family members or carers may need to be involved. Clinicians should avoid making assumptions based on age or frailty, and respecting patients' autonomy means ensuring patients are supported to participate in decisions. All patients should have fair access to rehabilitation after surgery, and timely mobilization support is important for recovery, but patients may have different needs. And ethical decision-making involves working together to balance clinical guidelines with patient-centered care. So, finally, some adaptations to special populations. First, patients with receiving palliative care. There, the focus of mobilization is not on recovery goals alone, but on comfort, dignity, and quality of life. Mobilization should be guided by the patient's wishes, comfort levels, and overall care goals. In some cases, gentle movement may be beneficial for comfort and pressure care, while in other cases, rest may be more appropriate. And the key ethical consideration is ensuring that mobilization support, comfort, and respects individual care priorities rather than following routine protocols. And the second is low resource settings. Mobilization after hip fracture surgery may need to be adapted due to limited staffing, equipment, or rehabilitation space. The focus is on using practical, safe, and sustainable strategies to support early movement and reduce complications, even when resources are constrained. And finally, patients with cognitive impairment should not be excluded from early mobilization after hip fracture. Although cognitive impairment can make mobilization more challenging, evidence consistently shows that these patients still benefit from early and continued mobilization, and delaying it is associated with worse outcomes. And even patients with moderate to severe cognitive impairment can benefit from structured rehabilitation. And strategies to support mobilization in these patients with cognitive impairment include graded mobility progression, frequent mobilization, tailored communication, and creating a cognitive supportive environment. That was all. Thank you.
Thanks very much, Kristen, and thanks to all our speakers. They're excellent. Katie, do you think we should do the final scenario? What are your thoughts?
I think we could go to Joanna's comments and then move to the Q&A because we've got lots of questions in the chat.
Perfect. Sounds good to me too. Joanna.
Thanks, Katie and Lauren. These have been really great presentations, and I'm looking at the questions in the chat as well. And there is one question as well from Ruben talking about after discharge and how to manage mobilization at that point. So some of my comments, I'm just going to go through a couple of comments, and some of them will address Ruben's question. So I think in the hospital, we're finding that caregivers are not likely to be there when assessments are being made, or communication around mobilization with the care team is being made are being made. And so even when a physiotherapist comes to visit patients, we hear from caregivers that they weren't there and they missed it. So they missed those conversations. So I think that there is a potential to sort of highlight the role of caregivers if they are able, and that's a huge qualifier, if they are able, in promoting mobilization, not just in the hospital, but once the patient comes home. We've also heard from patients and caregivers that there are really huge gaps in discharge planning around arranging rehab and community support for mobilization. So we really need to sort of translate these early mobilization strategies to care in the community, especially around physio. We've heard that if patients have caregivers, the caregiver may help with them with the early mobilization and the continued mobilization once they've been discharged. But care recipients are also very afraid of their care recipients falling, and a lot of them don't actually have the strength to support someone if they're trying to help them at home. And so we do hear a lot of that. If patients don't have caregivers and they're having trouble with other issues around activities of daily living, like cooking, getting groceries, dressing themselves, mobilization exercises are often not a priority for them. So I think there's also opportunities for us to sort of to realize like the broader context of patients' lives around some of these recommendations for mobilization. We've also heard a lot of a variable account of what happens with physiotherapy after patients are discharged. Some patients talk about not having physio at all, or they were told to go online and check out resources for exercises, or they think they've arranged for physiotherapy to come into the home and then a physiotherapist doesn't materialize for them. So I think there's a lot of continuity of care issues, and this may just be the Canadian setting, but we're hearing a lot of that from patients and caregivers around, touching on this issue of early mobilization. So that's all. That's all I had. I just wanted to, I think that those comments kind of sort of cover many of the points that were brought up in each of the presentations. And so We just have to be aware that our efforts are not always going to be followed through for various reasons from the perspective of patients and their caregivers.
You know, I think, and it's wonderful to see so many people come to this, and I hope more will listen to the recordings as well, because this is a challenging patient population, without question. There's a lot of issues. The hip fracture comes out of the blue for people, but they've already often been trying to figure out how to maintain at home and how to work together with their families. So, you know, this is what we're looking for is, of course, trying to get them back on the path to that recovery. But it is a really coordinated effort, and we certainly shouldn't diminish the importance of having support people for the patients. And if they're available to support the support people, and if they're not available, to figure out how to get supports to them in some way or form. And this is not an easy situation, but hopefully the start of early mobilization is we can at least get them started postoperatively down the right path. But this is a complex patient population to deal with, without question. Katie, how do you want to? So thank you, Joanna, first of all, for your insights, I think, and thanks again for great presentations. Katie, do you want to go back through questions? What do you want to do here?
Yeah, I think we can go back. So I've scrolled back the chat so that people who got their questions in first, we can ask that question. And maybe we can put the question out to the panel members. And if anybody's happy to pick up a question to respond to. So the first question we had is from Ruben in Chile. And Ruben's asked, which assessment tools do you use to evaluate post-surgical immobility caused by fractures? And while we were chatting, Julia has responded to say in BC and Canada that they're encouraging the use of the Cumulated Ambulation Score, the CAS, as a multi-day outcome measure. And we also have Melissa, who's jumped in to say that there's loads of indicators that you could measure. So things like length of stay, return to function, infections, pressure ulcers, increasing care hours post-fracture. So there's lots of different suggestions coming through in the chat. But I guess for the panel, are there particular assessment tools that you would use to evaluate post-surgical immobility after a hip fracture, or any measures that you would particularly recommend?
So I can say for people in Canada, there is an opportunity to actually measure early mobilization and daily mobilization through CIHI. There is a special field in CIHI. But again, going back to some of the points, you're going to be measuring by default for early mobilization and daily mobilization based on the complications of what the patient's experiencing, which will very much come out in length of stay and other indicators.
I think the CAS is a really good suggestion. It's a really quick tool to use. It was alongside the new mobility score. It was cited in the evaluation of outcome measures that are used and their psychometric properties in the American Physical Therapy Association evaluation of measures used in hip fracture rehabilitation. But it's quick. And one thing that we looked at recently is that it's not just early mobilization of any type, but it's the extent of early mobilization that a person can do for themselves that's associated with outcome. And the CAS allows you to measure how much support is required to enable early mobilization. So I think it's a really useful tool, so that you're not just measuring, did they do it? Yes, no, which is what we have in a lot of the audits internationally, but you're actually looking at the extent of early mobilization that an individual was able to do for themselves. And it gives you something to work towards. And it's not too burdensome as a measure when everybody has a busy, long patient caseload. I don't know, does anybody else have any further thoughts on assessment tools that are used in other contexts? If not, I can scooch on. Now, the one thing we will fail here is that because I'm scrolling down the messages, when people who are here on the call are responding to anything we say, I'll probably need you, Lauren, to pick that up for me then. Because I can see that a new message has come in, and I'm imagining it's in response to what we've just spoken about.
Okay, I'll go to the bottom end, Katie. You start at the top
Yes.
end.
Yeah.
And bring them in.
Sounds good. So there's a new message that just come in. Is that related to our discussion?
Just agreeing with what you're saying.
Okay, lovely. That's what we like to hear. Okay, so we have assess the impact of invitation design to, because I think that's a similar question. Okay, after discharge, how do you manage social cases involving patients who do not have family caregivers? And I guess that's a point as well around mobilisation. If we're struggling to achieve it and we're thinking about discharge planning, and then when somebody goes home, I don't know if any of our other panel members would like to pick that one up to respond.
Yeah, I'm happy to do a few words on that. So normally, there are certain cases where they don't have any family or caregivers, and here in the UK, there are different pathways where the patient can either go to rehab, where they will have an MDT there, or they can go home with community therapy coming in, and also having carers as well. That's provided normally by the local council, so they can go and help with either getting them out of bed, with personal care, and just maybe few participation or mobility, up to 4 times a day. At least that's how it works here in Birmingham, which I'm assuming it will be similar to other councils in the country.
So it is, we're quite fortunate, aren't we, really, in the UK, that we've got such a, well, I would say that everyone would say that it could be better everywhere. The grass is always greener, but there are infrastructures in the UK for community support and rehabilitation that aren't in other places. Carmen, do you want to step in?
Yes, I will just introduce the example of Portugal. Here, the patients can get in clinical pathways regarding the continuous of care in special units of rehabilitation where they are admitted for 30 days so they can regain some function, or 3 months so they can be completely autonomous, and then they go home. But it's also a big problem here in Portugal because we have lots of patients with hip fractures, and we also are still struggling with the patients being operated early. So when they get surgery and after surgery, it's harder to put them fit. So it's also a problem here in Portugal.
Yeah. Rhoda.
Katie, again, I'm just going back to the certification, and we've had submissions from all over the world, and absolutely the way that it's done is very, very different. I think that what we can agree to, or certainly what we've heard, is that there isn't one answer, but very much it needs to be about education wherever possible, and that pre-planning up front. So that whole assessment as soon as the person comes in and start looking at what they're able to do, and starting to develop those realistic expectations with the focus of discharge planning from admission. So I think that's the agreement in the approach as to where the person's going to go is very much dependent on the resources that are available.
Yeah. Wholeheartedly agree. Lauren, is there, I can see more messages coming in at the bottom of the chat. Are these in response to the current question?
Yeah, just a lot of them really were saying the same thing. It's so variable. I think within countries, across countries, different regions, in terms of what patients are able to do. And I think this is this part where you need to be really flexible in your thinking in terms of what's available and what might you be able to do to provide supports to people. But yeah, it's basically saying the same thing. This is in Canada, it's varying. In Portugal, it's varying. People across countries saying this is a challenge. I think it's nobody has any easy solutions, right?
It's a space for where we need to align, I guess, in a lot of regions, policies around moving from hospital to home, but also actually matching that up with resources to enable people to be at home. So I do think it's a global issue, and hopefully we can, through the network, look at the post-discharge setting and how we can kind of optimize recovery in that space. Okay, next question. And I think that this, Shanil, this came during your presentation. So it was from Chiara, and she's asking, I'm curious as to the 90 systolic blood pressure as a criteria and where it's come from. And do you also consider symptoms? So Shanil, are you okay to take that one?
Yep. So the 90 systolic normally comes so it depends from trust to trust. So this is what we use here in our as our guideline. And as far as I'm aware, it's based upon the NIST guidelines. And regarding the symptoms, yes. So if someone has a postural drop, it doesn't necessarily mean we are going to stop mobilizing. It's a case where we'll go by symptoms. If the patient is symptomatic and is hindering mobility, then yes, we will address it. However, we have patients who have long-term postural hypotension, but they are asymptomatic. So these are patients we will just carry on. And in certain cases, especially after surgery, where they would probably lose a lot of blood during the surgery, they'll be dehydrated. So what we do is we tend to use some different aids. That could be an abdominal binder, a bag of fluids as a bolus. So we have different ways of going around that.
And I think that nicely leads on to your next question that Julia had asked. Would you try some mitigations? And has also referred to bolus of water or abdominal binder or isometric holds of lower extremity. So I think ultimately what we're trying for is that we want to get people up and you try everything you can in order to get them up, rather than, as Lauren said earlier, looking for reasons to delay mobilization. So it's that kind of shift in culture and perspective, which might just seem like bread and butter to a lot of people on the call, but for some contexts, it is a cultural shift that's still required. We've had a few comments around mobilization and why would mobilization be delayed if the patient is non-weight bearing? Could you use other mobility aids to continue ambulation? So like, for example, a platform walker. And I think there was a flurry of messages that came through saying that non-weight bearing shouldn't delay mobilization. You still get somebody up to the chair. Yes, because these people are at higher risk of complications. We wouldn't like to delay mobilization. They need more interprofessional discussion. And I think at a starting point, speaking to your surgeon to say, are we really sure that we're going non-weight bearing here? Just to open the conversation. And then lots of people talking about different equipment that they would use to support patients who are non-weight bearing to get up, and lots of different brand names cited, but I think we can all picture the equipment that you will be using. So does anybody on panel want to make a comment around non-weight bearing and its implications for needing mitigating strategies or it leading to delays in mobilization?
You know, I think it's always an ongoing discussion. If it's not your culture to have people up, that people thinking you can't do it. But I think we also, when I'm listening to those conversations, thinking we're kind of mixing two things about mobilization and walking. And so it's like, you know, non-weight bearing may make it so it's, you know, until you clear something with a surgeon or you feel that the surgical stabilization is there, that you may not be walking as much. But that does not mean the patient should not be mobilized and be up in the chair or doing whatever you can within there. Absolutely, for trying to keep them moving. And it really is a cultural shift. If your surgeons don't believe in weight bearing as tolerated, that it's a real shift to do that. But I think there is more and more evidence, and from the guidelines around the world, where, you know, UK, Canada, these are, and we did a sort of a paper recently on it saying they're really, you know, there is not good evidence to say you shouldn't do it. So I think it's something that it's just a really hard cultural shift if that's not what's happening. And you've got surgeons who are quite resistant to it. And, you know, we found that I think one of the most effective ways is it's of course the senior surgeons convincing often the junior surgeons, or vice versa, that, you know, this is what I do. I have the same patients you do, and I don't have any more complications. But there can be a cultural shift. But certainly you're right. Whatever you can do to keep the patient up and moving and getting them out of bed, which is so important for these people. And I just want to follow, this is one of the later questions. Somebody says, what is your take on CPM? And I'm going to assume that this continuous passive motion, and that many parts of the world are still using it and have good outcomes with range of motion. And I think the only part that about the CPM that is sort of dangerous, if you will, to use is that it promotes being in bed. You can only use the continuous passive motion machine if you're in bed. And so that kind of is working against the other message you're doing, which is like, get the patient sitting up. They become more alert, you reduce delirium, you're doing everything. And so I think you have to have very strong rationale for why you wouldn't want that patient to be up and sitting, and I think there was a question, Katie, that you're going to run into that talked about passive and the evidence for passive versus active movement. And probably we should be saying active assisted versus just passive. If the patient's not able to actively doing it, trying to get the patient to engage when you're moving them. So I think our answer is patient engagement as much as you can in participating in their exercises. If they're absolutely not moving, then passive is better than nothing. Active assisted is better than passive, and active is the best. So where you're working through your piece, and you may have to start at one end and move up, but your goal always is out of bed, up and out of bed, to reduce delirium, to reduce complications, and engaging the patients as much as possible in whatever way you can, would be my message. Katie, or other panelists, other things to offer?
Just a quick comment. We say that we should always mobilize to the highest level.
Exactly,
Yes.
Chris.
Yeah, no, absolutely. And we do have the evidence to say that the more that is done, it's not just about doing it as an indicator, it's that more is always better, that individuals can do for themselves. And if you are struggling with wider MDT and moving to unrestricted weight bearing, you can use our global position statement, and we can share the paper that's saying, globally, the network has taken a stance that it should be unrestricted weight bearing for all. And if it isn't, it should be a very, very strong justification documented as to why not. And I think that leads on to our next query. We'll do this as the last one, actually, because we're coming up to our last minutes. And there's a comment around hip precautions given to folks with cognitive impairment who struggle to follow them. And I think we've actually got quite a lot of evidence from biomechanics researchers that say even people without cognitive impairment, when they are prescribed restrictions or limitations to their weight bearing, they don't do it. Even when patients are prescribed unrestricted weight bearing, they restrict because they do as much as they can do. So there is an element of, you can write whatever you want on the page, but patients are going to do their own thing. And we know that from the biomechanics evidence. So if you're prescribing hip precautions with somebody with cognitive impairment, they're not going to follow them. I think we just have to be real about that. And then we need to be going back to the MDT and saying, okay, they're not going to follow these precautions. So, future patients, is there anything that you can do at the point of the surgery that would make you more comfortable not to have precautions in this instance? But I think precautions are on the way out, but that's a personal viewpoint rather than something that's
just going to say
there
the
with the
same,
evidence.
Katie.
They lead to activity avoidance as opposed to enabling mobility, which is what we're all here for. Lauren, I'll pass to you for our closing remarks.
Yeah, no, so yes, and I completely agree on that end, is that the precautions, when we say patients are not going to follow them, patients are going to do whatever is the easiest way and the sort of least painless way they can to move and get out of bed. So you can state them on paper, but patients are going to do what they're going to do. And our goal is to get them moving as much as possible in a safe way. So Katerina, I think you're going to bring up one more slide, because we will, as I said, this presentation and all will be, the webinar will be recorded and released on the website shortly, as will the overall module, which covers sort of, this was a nice summary of it, but you can get into more details in the various areas when the module is released. So please do visit our website. And then we do have 3 more regional congresses that will happen this year. And I think Kateri's going to bring them up because I have not memorized the dates of when they're happening. They're all going to happen this fall. If you're from Canada, we already held ours in March in Toronto. So the Canadian Congress is gone. But we do have them coming up in Asia Pacific in Bangkok from the 3rd to the 5th of September, in Edinburgh, in Europe for the 8th to 10th of October. Latin America is being held in Buenos Aires, and it will be in the 3rd to 4th of December, and there will be one in Columbus, Ohio in the US from the 4th to December. So please do check out the FFN website if you're interested in attending. These are really excellent meetings where you get to meet with a lot of like-minded multidisciplinary people who are very interested in improving people with the care of fragility fracture. So this is not simply limited to hip fracture, which is one of our, one of the big fragility fractures that can happen, but it really looks at vertebral, upper extremity fractures and other lower extremity fractures as well. So please, if you're not a member of the FFN, please do join. There's lots of resources here. We like to share them. We try to keep them free. And so we would be delighted to have you as a member of the FFN. So, and I want to just end by saying thank you to our speakers. Great jobs on the presentations and really summarizing the work that was done in this early mobilization module. And thank you to all of our attendees for listening in and being so active on the chat. Really appreciate all the comments and the thoughts that were coming in from all of you. So thanks very much and have a nice day, evening, night, wherever you may be in the world. And we will chat again sometime soon.
Thank you, everybody. Lovely to see you all.
Thank you all. See you soon.
Bye-bye.
Thank you. Bye.
Thank you. Bye.
Good. Okay, all good. Thanks all. You guys have excellent talks, Carmen and Kristen. That's really well done. And thank you, Katie, for doing all the
Thank you
hard
for
work. I was just
sharing.
doing the intros.
Bye. Thank you.
Just
Thank you
reading.
for everything.
In the
You were
middle of
great.
Kristen's talk, my 2 boys came in with flowers for me. I was like,
You should go and get it now.
Yeah.
Yes, I will.
Yes, go enjoy your evening. You guys are into the evening, I think.
Yeah.
It's at midday. I'm going to go have
Bye.
lunch. Okay, see you later.
See you.
Thanks, Katarina. If that's you, that's regional. Thank you so much.